Good morning, everybody. Thank you for being here bright and early. I also want to welcome our online audience to this activity, Sharper Focus on Geographic Atrophy, Imaging-Based Strategies for Retina Specialists. We have a lot of content today to cover in 1 hour, but hopefully by the end of this activity, you will be able to learn a lot about imaging biomarkers and treatments for geographic atrophy. So we have designed a very good program. I'm Arshad Khanani with Sarah I Associates. I'm joined by my good colleague, friend, and essentially a mentor, Glenn Jaffe, who's a world-renowned expert in imaging. So you will see a lot of OCT imaging and other images, and I think Glenn, nobody teaches us better than Glenn when it comes to images. So I'm really excited to have Glenn. Before we get started, this is the QR code you're going to see throughout the presentation. So you just scan it once, and you'll be able to answer questions. You'll be able to claim your credits for this activity at the end. You'll also have some cards on your tables. If you have any questions, please feel free to use those cards to answer the questions. So let's scan and let's get started with a warm-up poll. What is helping you sharpen your focus for today's session? Coffee or tea, breakfast, connecting with colleagues, curiosity about geographic atrophy? So go ahead and answer. This is a test poll. And we need some really loud music so everybody wakes up.
Or just look at our shots, shoes.
All righty. There is no right answer here, so we are here for all of it. So we'll go to the first pretest question. I'm going to run through these quickly, so please feel free to answer them fast so that we can get to the content. So the first question is, on spectral domain OCT, which single finding best defines geographic atrophy under the CAM consensus, distinguishing it from drusen and pigment changes of intermediate AMD? So go ahead and read the answers, and we'll get the polling going. Glenn, you're part of the CAM group, right?
Yeah.
There we go. We can make it quicker if you want so that we keep going to the content. Alrighty. So we'll show you pre-test and post-test at the end. So question 2, the 2 FDA approved intravitreal therapies for GA both act on the complement cascade. Which statement correctly pairs each agent with its molecular target? Hopefully you all know this, but please go ahead and answer. All right, we'll go to the third question. 70-year-old man, left eye, foveal sparing GA 2040, enlarging towards the fovea, fellow right eye, central GA, count fingers. Wants to preserve his reading left eye. What are the best next steps? Glenn, what would you do?
I'm hiding my answer. I'll wait to the end.
Good. That's what we wanted to hear. Okay. Number 4, 73-year-old women, right eye on an intravitreal complement inhibitor for extrafoveal GA. Returns for a monitoring visit. Most appropriate imaging strategy to track progression and screen for treatment-related complications. Great. Again, they're all on your phone, so please go ahead and answer. All right, so let's get started with some content and some imaging. So geographic atrophy, obviously all of us are aware, is advanced form of AMD, and it's irreversible, and it can now be slowed because of the approved complement inhibitors. And we know that it's a leading cause of irreversible central vision loss. I think it was a milestone when we had approval of 2 FDA-approved complement inhibitors to slow down the disease and hopefully keep independence longer for our patients. So in the next hour, we'll recognize GA on imaging, understand the therapy, and monitor it well. So Glenn and I will tag team with the content. Please feel free to raise your hand and ask questions if you have, or write them on the cue card. So why is it relevant? Because GA is common. It's more common than we think. And as we get older, the rate of GA goes up. And we know that more and more of our patients are living longer in this age. So we have about 1 to 1.5 million people in the United States living with GA, with millions more worldwide. So it's a common problem that we see in our clinic. It's one of the most frustrating problem we had before the approval of the complement inhibitors to slow down the progression. And you have a 40x higher risk of GA at age 85 than at age 60, as prevalence really steeply climbs as patients age. When patients get GA, obviously, they lose their independence, their quality of life. They lose reading. Their reading speed declines, or they're unable to read. They have low light vision problems. They have falls. They get fractures, and they can't drive. And I think one of the biggest fear I see in my patients is actually losing the ability to drive. And I think that's the question they keep asking me: how long do I have? Because if I can't drive, then I can't have independence, and I have to drive. Do something to help me. And many times, patients have functional deficit even before BCVA declines. And BCVA is a very poor marker of function. Many of these patients have metamorphopsias, they have scotomas, and other symptoms, even with good visual acuity. So what has changed? I've been in practice almost 20 years. Glenn has been in practice for, we don't want to age you, but
Long time.
a long time is a
Longer than our shot.
long time is a good answer. So, we had these patients, they progress, they lose their independence, they ask us, what can you do? And we had nothing, right? So in 2023, it was a big milestone for the field, the first GA drug getting approved, pegcetacoplan, followed by the approval of evacencaptad pegol in middle of 2023. And obviously, either of these drugs don't restore function, but our hope is that by slowing down GA growth, we are slowing down the functional loss for these patients, because photoreceptor, losing photoreceptors in RPE correlates to function. And we know that very well. Obviously, we have to prove that in clinical trials, which sometimes can be difficult with variability and sensitivity of the test. Okay, so let's go to the polling question now. I hope you guys had enough coffee to answer. So the question is, how confident are you today in selecting candidates for and monitoring response to complement inhibitor therapy for geographic atrophy? Not at all, slightly confident, moderately confident, very confident, extremely confident. Great. Slightly, moderately, and extremely. Were you extremely, Glenn, there?
I was moderately.
I think it's a really, really good question, and hopefully through the presentation at the end, we'll be able to help you move to the right side. So Glenn, why don't you tell us about imaging techniques need to recognize geographic atrophy?
Yeah, so how do you actually identify geographic atrophy, and what are the methods that you use to do that? Well, I like to use a multimodal imaging approach, meaning that I'm using different imaging modalities together to come up with the diagnosis and also to monitor the patients as well. So let's start off with a case. You have a 72-year-old man, and he has a slight decrease in his reading speed, no metamorphopsia or distortion. You see these yellowish large lesions, large soft drusen, and if you look really carefully, there's a little bit of pigment in the center. And there's concern for early atrophy. And the question is, would you still consider this intermediate AMD? Has it progressed to geographic atrophy? So how do you actually determine that it's geographic atrophy? And there are different stages of the disease. And as the disease progresses, you're getting closer and closer to atrophy. And you have to be able to recognize the things that put the patient at risk for going on and progressing. So, excuse me, early on, you have drusen, which is a sign of AMD, and the drusen tend to get larger over time, and they have certain characteristics that may put them at higher risk. Intermediate AMD means that you have large drusen with or without pigment, and late AMD has two flavors, neovascular AMD or geographic atrophy, and we're focusing on geographic atrophy today. And depending on where you are in this continuum, that helps to determine how often you're going to be monitoring the patient, whether they're going to be eligible for a clinical trial, and how they're likely to do in the long run. And so this particular patient that I told you has high risk. He's at intermediate AMD, but is at risk of developing atrophy. So what are the progression features? And I mentioned large drusen, and large drusen greater than 125 microns are the sign of intermediate AMD. And how big is 125 microns? I use measuring sticks in the retina to help tell me how big things are. And the measuring stick for 125 microns is the width of a venule. So a venule width is about 125 microns typically. And there are different types of drusen that put the patient at higher risk particularly. So what you're looking at, these large, soft confluent drusen are a high risk, but also there are cuticular drusen, which have these sort of sawtooth appearance, and there are nodular or calcific drusen that have look hollowed out. And these types put the patient at higher risk. Focal hyperpigmentation, I mentioned that in that patient previously, there was a little bit of pigment in the center. That's an independent risk factor. And we see that on OCT as a sign that the RPE are unhappy. They start migrating from their monolayer into the retina, and we see those as hyperreflective foci, bright little spots in the retina that are a sign that the RPE are under stress, and this is a risk factor for progressing to atrophy. The other thing we look for are subretinal drusenoid deposits, and you may know those as reticular pseudodrusen. The current terminology is subretinal drusenoid deposits, but that also puts the patient at a high risk for progression. So we mentioned that atrophy is the endpoint for the advanced form of dry or non-neovascular AMD. And if you look histologically, you see loss of the RPE, loss of the photoreceptors, and the choriocapillaris, the little sprinklers pointing towards the RPE, are also lost. And on OCT, we see loss of the RPE, you see outer retinal atrophy, and choroidal hypertransmission. And many of you heard the term CRORA for short. That comes from our Consensus on Atrophy meeting group, the CAM group, which is what Arshad alluded to. And that group was convened to identify the imaging modalities that we use to determine atrophy and follow it, and also to establish the nomenclature so that we're all speaking a common language. And this particular one is CROR, which I'll talk about in a bit more as to how that's defined. But we're talking about the atrophic endpoint distinct from neovascular AMD. And another point of terminology, geographic atrophy specifically refers to the atrophy in non-neovascular AMD. And when you hear the term misused when people are talking about neovascular AMD and then they get atrophy, technically the umbrella term and the term that you should be using is macular atrophy. So macular atrophy is the general term, and geographic atrophy is a specific case that occurs in eyes with non-neovascular AMD. So you can diagnose geographic atrophy just from the OCT. But I like to use the other modalities to help in the evaluation and certainly for monitoring it. We use modalities that include color fundus photography, fundus autofluorescence, near-infrared reflectance imaging. But autofluorescence is very nice because it's very visual, and it's visual for the patient as well to see a black spot on their image. And it's a pretty nice representation of something bad. When you see a black spot, that's not something you want. So I use the en face image, which suggests that atrophy is there. And that en face image can be any of the ones I just mentioned, autofluorescence, OCT, et cetera. But as I mentioned, OCT is what we use to actually diagnose geographic atrophy. We also use fundus autofluorescence. And with fundus autofluorescence, you have lipofuscin that is contained within the RPE cells as with aging and with stress. You get this dysfunctional RPE show very brightly, the hyperautofluorescence. When they're dead or they're absent, that's where you see the black spots, the hypoautofluorescence. And that gives a very nice, clear view. The borders are not often super sharp, but usually you can identify the atrophy from the hypoautofluorescence. Now, it's also important to recognize that just because you see hypoautofluorescence doesn't mean that's necessarily geographic atrophy. If you have pigment in the retina, if you have blood, you have mediopacity like a cataract, that can cause a dark spot on the retina, so you have to be able to differentiate it. And this just shows the hypoautofluorescence, that black spot in the center, and you see it against the normal background autofluorescence. And we can quantify that over time. And typically we're measuring the area, which is in millimeters squared, and we can track the growth rate. And as Arshad's going to be talking about, the growth rate of the autofluorescence is the pivotal trial endpoint that was the endpoint that got both pegcetacoplan and avacincaptad pegol approved. So here you see the atrophy, the hypoautofluorescence, and around the hypoautofluorescence is typically where you see the sick or dysfunctional RPE. That's the hyperautofluorescence. We describe different types of patterns of hyperautofluorescence. The diffuse or banded pattern are the most typical, and here you see the banded pattern, which looks like a ring surrounding the hypoautofluorescence. There's one particular pattern, the diffuse trickling pattern, which grows particularly fast. And the other thing that I find very helpful when I'm looking at my patient, in addition to looking at the autofluorescence, is to look at the margins of the lesion. And that's in the area where you see that bright band. And extending outward from that, you'll see loss of the outer retina, especially as loss of the ellipsoid zone. And I use that when I'm thinking about where the atrophy is going to go, because it tends to go into the area where the outer retina starts to get lost. And so I pay attention to that on the OCT. So I mentioned the different types of hyperautofluorescence patterns. The one that grows the slowest typically is when you don't have any autofluorescence around that lesion, or hyperautofluorescence. That's actually pretty uncommon. Most of the time, the patient has the banded or diffuse pattern, and in clinical trials, often the patients are recruited as an inclusion criteria. They have the banded or diffuse pattern, but that actually is most of the patients. But it's the diffuse trickling pattern that I mentioned that grows the fastest. So the typical growth rate, somewhere on the order of maybe 2 millimeters squared per year. The diffuse trickling pattern can grow up to 5 times that fast. So I mentioned C-RORA, and that OCT is the terminology, and I would mention that the CAM group has decided that OCT is the primary modality upon which we base the diagnosis. And there are terms that I think are important to understand, and I'm going to mention C-RORA in a minute, but you may have heard the term nascent GA. This was coined by one of my colleagues, Robin Geimer, who's also part of the CAM group. Her definition preceded the CAM definitions, and this was nascent GA. And she describes subsidence, or a sinking down of the inner retinal layers, the inner plexiform layer, and I'll show you that in just a minute, and a hyporeflective wedge. You hear the term IRORA, which means incomplete RPE and outer retinal atrophy, and then C-RORA, which is complete RPE and outer retinal atrophy. So what's the difference between the two? It's really a matter of the magnitude of the size of the lesion. And when we were deciding on how big a lesion we would use to call the OCT correlate C-RORA, we tried to, and this was just empirical, decided what width do we think that people could reproducibly measure and say that's atrophy. And 250 microns was what was picked. And as I mentioned, that was empirical. There was no real scientific basis for it, but that was arrived at by consensus, and that's what the consensus atrophy meeting group is based on, is everybody trying to come together to come to agreement. And as it's panned out over the subsequent years, it's turned out that 250 has been a pretty good cutoff for identifying the size at which you can reproducibly measure, but also the size at which, once you hit that point, that's a pretty irreversible endpoint. So here you see it visually, and on the left is nascent GA. You see that dark wedge adjacent to the area where it looks like the inner layers are sinking down. You also see that same appearance very typically in iRORA and CRORA, and you see that on the two adjacent images. The one on the right with the CRORA shows the sinking down, but the criteria are loss of the outer retina. So you see the bands, and then all of a sudden they just end. Then you pick them up again. Those are the layers in the outer retina, the ellipsoid zone, the external limiting membrane. And because the RPE is lost, which is one of the other criteria, loss of the RPE or attenuation of the RPE, the signal of the light goes into the choroid. And so that's why you see that bright band in the choroid. So it's loss of the outer retina, loss of the, or attenuation of the RPE, and choroidal hypertransmission. Those three things define CRORA, and the width has to be 250 microns or more. iRORA is exactly the same. The only difference is that it doesn't meet that 250 micron threshold. So just practically speaking, how to identify geographic atrophy? I take one of those en-face imaging modalities, color fundus photography, OCT you can look at en-face, near-infrared reflectance, fluorescein angiography even, and that gives you the overall, it's like the survey to show you the atrophic area. And then I use those CAM criteria, which I just mentioned to you, to say, is it geographic atrophy? The other thing that's really important is to be able to identify the center of the center of the fovea, because as you hear about all of these descriptions in the clinical trial, foveal involving, non-foveal involving, why do we care? It's because the central regions are the most visually sensitive regions, and to be able to know how close you are to the center, you have to be able to identify it. And you can't really do that on autofluorescence. It's just not accurate enough. So we use OCT to identify the center point. And I use a lot of different clues. The first one, and the most obvious one people think about, is the foveal depression, the area in the center where the retina is the thinnest. So you see that here. The other thing that happens is that in the very center, the retinal layers disappear. And so you see the retinal layers going across and then they're gone. I also use this triangular area of the outer nuclear complex, the dark hyporeflective region that you can see here. That also helps to define the center. But the one that I like the very best are where the ganglion cell layer and the internuclear layer apices are widest apart. What do I mean by that? So when you're looking at that image, you'll see the ganglion cell layer. That's the layer just under the brightest layer, which is the retinal nerve fiber layer. And it comes to a point right by that dip. And if you take the scroll wheel on an OCT on the mouse, and when you scroll back and forth when you're looking at the OCT on the screen, you'll see these points move back and forth. And the point at which they're widest apart, and that also holds for the internuclear layer as well, the dark hyporeflective layer, that's the halfway between, that's the center point. And that, for me, that's often the best way of looking. The other thing, and so here you see the ganglion cell apices, what I'm talking about in the internuclear cell, or the internuclear layer apices. And then finally, you can often see a bump in the fovea. It's the photoreceptor bump that I call it. It's where the photoreceptors are most elongated. And you see that the ellipsoid zone, that's that bright band above the RPE, gets bumped up. The external limiting membrane, the fainter band, gets bumped up. And it's because those photoreceptors are elongated. So I use all those anatomic landmarks to say, where is the center point? So we're going to start the next poll. So our 72-year-old is returning. And here you see the description, the sharp demarcated hypoautofluorescent lesion, bright junctional margins, foveal sparing, OCT. We see C-RORA. So answer the question, please. Learned something.
Great job, Glenn. 100%. That's fantastic. I don't think if I can beat that, but this, as I said, I always learn from you. Some of those, imaging biomarkers, the ganglion cells, and coming together. Sometimes it's hard to identify the center point, right?
It is.
And especially like when you're looking for that in clinical trials. Many times we think it's not central point involving, and then you read it and you say, yes, it is. So I think those biomarkers are important. Okay, so let's talk about the complement system. And the goal here is to obviously discuss how the treatments work so that we can help our patients slow down geographic atrophy. So the complement system is very complicated, as I say, but I think just to summarize and make it simple, it's a part of innate immunity, and it's a very tightly regulated cascade. So you can see on top there's classical lectin and alternate pathways. They all come together at C3, which is basically the central conversion hub, and then downstream they go down to C5, and then past C5, which is more downstream, you have the membrane attack complex, and that's where the cells start to die, and we start seeing atrophy and choriocapillaris injury. So the idea is that the complement system is a cascade of innate immune proteins that clear debris and pathogens from your body. And if you go into overdrive, you start having a loss of photoreceptors and RPE cells. So when you look at geographic atrophy, as I said, it's an overactive drive of the complement system, and really it causes inflammation, and the inflammation and the MAC attack complex, as I said, leads to cell loss, and that's how the atrophy expands. And Glenn kind of covered the biomarker we are looking at, hyperautofluorescence at the edges. You have the banded and the trickling. So the complement system is very active in overdrive in some patients, and we can actually see on imaging biomarkers which patients are going to be fast progressors. What about genetics, right? So we have dry AMD is a disease that's genetic, that has complement overactivation. We have social risk factors like smoking, but genetics have been established for a long time with the GWAS and other studies, and the strongest AMD risk factors we see are genes variants for CFH and C3. And these complement components are embedded in drusins and at the sites of RPE stress, and that's why you see the loss of these cells. And it makes sense to kind of target the complement pathway so we can actually slow down cut the inflammation and slow down the loss of those cells. So as I said, all the pathways come together at C3, then go down to C5, and then MAC attack complex, and then atrophy. And when you look at the injury, the injury runs RPE to photoreceptor to choriocapillaris, and that's why when Glenn showed you, the images, you can actually see the loss of RPE photoreceptors and of course thinning of the choriocapillaris. There's a lot of discussion about whether dry AMD is actually a perfusion problem, but I think clearly based on the availability of treatment targeting complement, we know that complement pathway actually plays a big role. So now let's look at specific components. I already covered that all the pathways come to C3, so blocking C3 is an ideal target. Then downstream you have C5, so you can also ideally target C5 and then help control the inflammation because of hyperactive complement system. And the target has to be very specific. And the target, what we have learned from doing trials, Glenn and I have been doing a lot of trials over the last 2 decades, and almost all failed except for pegcetacoplan and avacincaptad-pegol. And the reason for that is that we need to be specifically targeting the complement system, and we need to target aggressively in that sense that we have to shut it down. So we have had other treatments in the past we looked at for alternate cascade and others. They failed and showed no benefit. So I think the idea is that we need to make sure that whenever we have a treatment, it really blocks the complement system in all pathways. So talking about treatments, as I covered, 2023 was a milestone for our field to have 2 approved treatment. Pegcetacoplan was the first approved treatment for geographic atrophy. It's a pegylated peptide that binds C3 and C3b, and it blocks the cascade as the central hub, as I said. And then avacincaptad-pegol, which was approved in August of 2023. It's a pegylated RNA aptamer. So one is a pegylated peptide, the other one is an RNA aptamer that binds C5. And again, this is more downstream compared to pegcetacoplan. When you look at the route of delivery and dosing, both of them are delivered in clinic intravitreally, routine injection, like hundreds and thousands of injections that we do. Pegcetacoplan is 15 milligram. Avacincaptad-pegol is 2 milligram. And the cadence based on the label for pegcetacoplan is monthly or every other month based on the Derby and Oak study, where we studied pegcetacoplan every month, every other month compared to sham, and looked at the GA lesion growth, as Glenn said, which was the primary endpoint. Because the regulatory agencies understand that BCVA is a very poor marker of geographic atrophy and has variability. So having a structural endpoint for geographic atrophy clearly makes sense. Avacincaptad-pegol, based on the GATHER1 and GATHER2 studies, was studied on a monthly basis in those trials in the first year. In the GATHER2, there was a monthly arm and every other month arm. But the label obviously is based on the data from 2 years, but since it was studied only every other month in the second year, the label is monthly for avacincaptad-pegol. Okay, so let's go to the polling question and see what we have here. So when you look at geographic atrophy secondary to AMD, what is the primary role of complement inhibitor therapy? Slow the progression of atrophy, reverse established vision loss, regenerate atrophic retina, eliminate the need for ongoing monitoring. So please go ahead and answer. If I don't get 100%, Glenn, I shouldn't be here then, right? All right, 100%. Thank you.
Perfect.
All right. So in terms of treating geographic atrophy, I think this is a big question in clinical practice. I think a lot of physicians that practice, private practice, academic setting, we're all busy, right? And geographic atrophy actually takes time to discuss the treatment option. And I think here what we want to do is kind of simplify that for practicing clinicians so they can use evidence-based strategies to kind of educate the patient about efficacy and safety. Again, the goal of therapy, as all of you got it correctly, is to slow growth and protect the function of a patient, that whatever function they have left. There's a lot of discussions in the community about, well, we did not see function prospectively in clinical trials. We saw a hint of it in third year in pegcetacoplan study, but the question was, at that time, when these studies were launched, I had no gray hair and no wrinkles, and our imaging tools were actually microperimetry, and other tests we had were not very specific. I remember we were part of both Derby and Oak studies, and one of the studies had microperimetry, and having patients with central GL lesions, it was very difficult to even get a test. So we believe that, obviously, and so do the regulators in the US, that structure correlates to function. It's a matter of showing function in a prospective fashion. That has been a challenge in geographic atrophy, but I'm very confident we have a lot more exciting technologies, image-guided microperimetry, OCT function, OCT, and other parameters that are being developed now, that hopefully in the future we can actually show that loss of photoreceptor cells actually results in loss of function. So when you look at complement inhibitor, I tell the patient, usually I have their historical FAF and OCT and multimodal imaging that Glenn taught all of us to actually get. And then I show the patient that they actually have expansion of their disease. And they say, well, what can you do about it? Well, we have available treatments that we can give you so that we can slow down the progression. And that actually resonates simply with majority of my patients. And after that, we talk about treatment burden, we talk about risk-benefit profiles. So in my practice, it's been very easy because these patients are desperate and they want something to slow down. And they notice that they have scotomas, they can't read, they have to turn their head, they're bumping into things, low light, they can't see. So I think it's pretty easy. I straightforward tell them that, this is to buy time, is to not restore your lost vision, is to keep what we have longer by treating you. And I think that actually resonates, as I said, with most of the patients. So looking at the data, when you look at the GATHER2 trial, avacincaptad pegol slowed down GA growth 14% at 12 months versus sham, and then you can see the decrease in GA growth. So I think people look at the numbers, they're like, well, why do we care? Well, we care because any growth, slowing that down, it's meaningful because, these patients may just have a very small area that's actually helping them navigate. And if we can preserve that area longer, I think that's a big benefit. And when you look at the GATHER2 study, the effect increase over time, very similar to what we saw in Derby and Oaks, and then the long-term extension. So what we have seen is continued treatment is needed. So when I'm counseling a patient, I'm not saying that this is a commitment for 3 months or 6 months or 9 months, but it's a lifetime commitment. And many of the times when I treat a patient, I don't treat them the same day I'm discussing. I give them the reading material so they can review that and then understand that this is a lifetime commitment, because what we don't want is somebody getting a few injections and then dropping out, because they need to understand that this is not to restore anything. And many of the complaints we get with complement inhibitors, just like we did in the clinical trials, I'm still getting worse. So it requires a chair time actually to explain every time that we are slowing it down. You will actually get worse even with injections. And they confuse that with wet AMD. And it's like, well, that's a totally different disease. So every time I see a patient, I say, you're doing great, you don't have any side effects. As you know that we're slowing the disease down, but you will progress. And I think what we have currently for you is what's the best for your eye. So when we look at the data from avacincaptad pegol, 14% in GATHER2, and then that increased to 40.5% in the open label extension. And then Derby and Oaks study, pegcetacoplan, as I said, had a monthly arm and every other month arm. And patient populations are also different. In avacincaptad pegol trial, non-center point involving GA lesions were enrolled. In Derby and Oaks, actually, we had all comers, majority of them obviously central involving GA. And what we saw in Oaks was the growth rate was 21% reduction monthly and 16% every other month at 12 months. And then Derby also had a treatment effect at 1 year, but barely missed the p-value. But then over time, in 2 years, actually showed a benefit with nominal p-value, and that resulted in the approval of pegcetacoplan as the first agent for treatment of geographic atrophy. And we recently saw the long-term GALE data, which shows very impressive reduction over time. So the key is that it's a long-term commitment. It's something I tell patients that the longer we treat, the earlier we treat, we're going to preserve their function and then slow down the GA growth lesions. So just to summarize, the data from pegcetacoplan over time, so you approximately 19% reduction, about 2 years, and then you increase that to additional 27% from 24 to 60 months. So I think, what we see is we see a treatment effect, as I said, that continues to increase over time. But when you look at, cross-trial comparison, you should not be doing that because it's not very scientific, but we see an effect in both trials. Of course, the baseline characteristics are different. The treatment mechanisms are different, but it's attacking the same pathway. And what we see is we see the increasing effect over time. So I think when patients ask about treatment, we say that we have seen consistent results in terms of slowing down disease based on the treatment with complement inhibitors. And so I think the goal is obviously to treat the patients, keep them motivated. I think motivation is the key, and it comes from the physician and the staff that you are slowing down even if you feel that you're getting worse. And I think the real world uptake has been, you know, variable, I would say, and it's growing over time. But I think not having that function prospectively has challenged many physicians. But I think our job is to educate that function is very hard to prove, even though we believe that we are preserving function in a prospective setting. But hopefully we do that in the near future. And when you look at the data from the RCA network and you see, you know, uptake of both of these medications over time, we're actually able to learn about long-term efficacy and safety of these agents. And again, as I mentioned, the pivotal endpoint is structure and not function. So I think when I'm treating a patient in clinic, because BCVA is so variable and we are doing Snellen, I'm actually looking at the OCT images and to see how they're doing. And my hope is that we're able to show, and there's a lot of, you know, artificial intelligence and other tools now, to show them the trajectory before treatment and then show them the slowdown of the trajectory after treatment. And I think what we have learned is that we need to intervene early. That's the other thing. If you have large central involving GA, like the picture in B here, then I think it's too late. And I think you need to intervene early so you preserve long-term function. And I give the example to my patients, like it's having a fire at your house. And if a small area like a garage is on fire, you may be able to preserve the house. But if the whole house is on fire, it's too late. And so I think as a field, we are moving towards early intervention before involvement of the fovea. And I think starting non-foveal, non-subfoveal, or even further away lesions with high-risk characteristics that Glenn talked about, I think is the key to actually help our patients. And I think when you look at visual acuity, you know, the GA and visual acuity, we can see some correlations, but we know that GA often grows faster away from the fovea. But the visual acuity actually drops quickly in central involved lesion based on the analysis. So I'm actually treating not just non-foveal involving GA, but also patients who have foveal involving GA. So now Glenn will show us some pictures and ask if these patients are good candidates.
Yeah, so just to amplify something that Arshad said, which I think is really important, there are a lot of factors that go into what drives your treatment decision. Certainly how close it is to the foveal center. We talked about how to identify the foveal center. But there are a lot of things about the lesions themselves that also determine how fast they're going to grow and how much they're going to affect the patient's vision. And one of these is whether they're multifocal, many individual spots, or a single one. The multifocal grows faster. The other thing is something I've called foveal invasion, which if you think of this central region as the visually important region, how much of that region is occupied by the geographic atrophy, because that will affect the patient's visual function. And then even if the fovea is not involved, you can imagine if the lesion is on either side of the foveal center, somebody can't read across. They might be able to read the 20/20 letter, but they can't read because they look across and they fall into the scotoma, the blind spot that goes along with the atrophy. So here's a patient, and you see the atrophy is encircling, but they're still able to read. So would you treat this patient with anti-complement therapy? And let's say the other eye was gone. So you have this remaining small island. Well, one of the things that we talked about is you have to be able to identify geographic atrophy as distinct from other conditions. This isn't even AMD. This is late onset Stargardt's or an ABCA4 mutation, and you can tell because of the peculiar looking pattern of hyperautofluorescence. That's not a pattern that we typically see in AMD. And also, you have to look at the OCT. You're looking for drusen or subretinal drusenoid deposits. That patient didn't have drusen, didn't have subretinal drusenoid deposits. So the first thing you need to do before you even say, is it geographic atrophy, you have to make sure that it's AMD. So that would not have been a patient that I would have treated. We also talked about, Arshad mentioned the new tools that we're developing to try and track how fast the lesion's growing. And a lot of these things help go into your treatment decision. And one of the things, and I do the same thing, I never treat the first day I've seen the patient. I actually like to have a window of time to see how fast the lesion's growing. I have all these various characteristics that I know may make the patient's lesion grow quicker, but I actually like to monitor them for several months just to get an idea of how it's progressing. And then it makes it a lot easier to have that discussion with the patient. So the prior growth rate goes into the discussion. The lesion geometry, like I showed you, is it on either side. Even somebody who has a foveal center point involving lesion, if it's small enough, they still may be able to read 20/30, 20/40 by eccentric fixation, and then you still have quite a bit to preserve. Once the fovea has been completely invaded by the atrophy, that may be too late. This is something I think Arshad is going to talk more about, but the indefinite injections.
So I think I covered most of this. Basically, it's a long commitment, and I think again we need to tell patients in advance, and I think that's why education is the key, taking time and I continue to educate. I have patients sometimes I see multiple times before they start treatment. So it's a disease not like wet AMD that if they don't treat in a few weeks they will lose vision. It grows faster than we think, but if they want to take a month or two, then obviously we give them that time, because you have injection burden and tolerance. It leads to chronic fatigue. We have, life expectancy and competing health issues. If somebody's 95-year-old and have central involving GA, probably not the right patient to treat. And then because the benefit accrues over time. And so my focus is treat early, in patients with actually very good visual acuity and minimal symptoms, so we can preserve the vision longer for those patients. And I think what I talk about is loss of independence, and I think that resonates a lot with the patient. And so having the historical imaging, talking about their symptoms and loss of function. So I think the key is persistence, and I think, a lot of times patients want to discontinue after a year or two. They get fatigue. And I think that's where you have to actually take time and talk about what the treatment has done and what the historical imaging showed and how we are helping them. Obviously, safety is something we have to discuss because these are intravitreal injections. They carry the risk of infection, and then, of course, they carry the risk of inflammation. Luckily, in both programs, the risk of inflammation is minimal. In Gather 2, we had no non-serious, inflammation. We only had one non-serious inflammation. There was no vasculitis in the first year or ischemic optic neuropathy. When you look at Derby and Oaks, the inflammation is also uncommon. There were no retinal vasculitis in Derby, Oaks, or Gale. We have seen that in the real world studies, and the rate is very low. Because the rate is so low that it's hard to know if it's 1 in 3,000 or 5,000 or 7,000. These are both 100 microliter injections, so the pressure does go higher. Some patients go dark, so you need to make sure that they can count fingers before they leave your clinic. If you have injection associated side effect, let's say inflammation, need to make sure we check the vision, pressure, we do a dilated exam, we look at the retina. Sometime you may need fluorescein angiography to make sure there's no vasculitis, and then obviously, treat it with topical or systemic or local steroids. When we look at the retinal vasculitis with pegcetacoplan, again, it was not reported in any of the clinical trials. It is reported in the real world, and it typically happens after the first injection. And I think what we have learned is to treat aggressively so we cannot lose vision. As I said, it's very rare event, and because the events are so rare, it's hard to know exactly the percent, because each studies have shown anywhere from 1 to 2 to 5 to 7,000 injections. So recognize, image, and decide when to stop. And then obviously, one aspect that people are doing is they're treating, because a single injection phenomenon, they're treating the worst eye of the patient first to make sure that there is no response. But I think the bigger concern that comes into play for patients is conversion to exudative or neovascular AMD, and we have seen that with both agents. And I think that's something I actually mentioned in our discussion. Talk about that there is a chance of getting wet AMD or CNV, and that increases over time as we continue treatment. What I reassure them is that we have good treatments for exudative AMD if they convert. And the challenge comes in when they convert. Now, do they want to stop the complement inhibitor because now they have to get injections for GA as well as exudative AMD? So sometimes this can be a reason patients don't want to start, or this can be a reason patient actually want to stop the complement inhibitor because the burden becomes double if now you have the side effect. Patients in both Derby and Oaks and Gather 1, Gather 2 did really well with standard anti-VEGF injections that were continued with complement inhibitors. So we actually know that they will benefit, but it's a matter of the treatment burden that bothers the patient. So I think the bottom line is we need to be honest with our patients, be realistic, don't overpromise that things are going to get better or be reversed. Be realistic that our goal is to slow down the worsening, and then risk and benefit discussion. So each physician is different, each patient is different, and I'm glad to see that we have 2 available agents that patients have the options to slow down their disease. Glenn, we have about 10 minutes left, so we'll move fast.
Yeah, so in the last section, we've talked about how to recognize geographic atrophy, the ways that you can treat it, who might be candidates for treatment, risks and benefits. And I think it's important to make a few comments about how you actually monitor them over time. And we can do this quantitatively. We did it quantitatively in the clinical trials. You can do it quantitatively in the clinic. And we use the same modalities to monitor them than we do to evaluate them in the first place. So you can use autofluorescence to measure lesion area and look quantitatively over time. And we're developing better tools that will assist you with AI, where that will help to map out the progression rates where the GA is likely to go, which is something that Arshad mentioned earlier. So in the pivotal trials, the lesion area on serial autofluorescence images was the endpoint, and you can do that in the clinic. You also can look at that hyperautofluorescent area. But as I mentioned, one of the things I really like to do is look at the OCT in cross-section and look at that area where the ellipsoid zone adjacent to the atrophy is expanding, and that's another helpful clue. And it's really the change over time. It's not just one single time point. So with OCT, you can track the CRORA, that's the OCT correlate of geographic atrophy. You can measure the distance to the center. So if it looks like the lesion is progressing towards the foveal center, I showed you how to identify the center point. And OCT is the way you do that, not with autofluorescence. One of the things that is important, you have to pay attention to the images themselves. And if you're using autofluorescence to monitor progression, the images have to be registered to one another, which means that if you were to superimpose the blood vessels, they'd line up. The software will help do that for you. But if you get an image that's off-center, and the next time it's in a different location, you can't do the registration, and the measurements that you make are not accurate. So you have to make sure that the photographer takes the image so they've centered the image nicely. And you can see that despite the fact that there is geographic atrophy, and in each of these cases it's affecting the center, the images themselves are nicely centered. There's a faster growth rate typically away from the foveal center, but if it starts growing more quickly towards the center, that is going to potentially change your plan for treatment. You also have to think about how often you're going to monitor the patient, because if any of you have had blue light autofluorescence, it's pretty bright. Typically, when the patient's getting treatment, I'll monitor them about every 3 months. If you don't know and they have intermediate AMD progressing to geographic atrophy, maybe every 6 months. If they have early AMD, you might just monitor them every year. But you need to change your monitoring plan depending on how fast the lesions are growing and where they're growing to. If it's growing farther away from the fovea and it's not growing at all towards the central area, you may still be able to follow them relatively infrequently. So I'm going to turn this over to Arshad for the conclusion.
Yeah, I think what we learned today, obviously based on imaging, identify the right candidates on multimodal imaging, talk to the patient about impact of the disease on their independence, discuss the risk and benefits of treatments, pegcetacoplan, avacincaptad, pegol, in terms of, also the treatment burden associated, get the baseline imaging, but also historical imaging to actually show the lesions are growing, and then have a monitoring schedule to monitor the progression of the disease, but also the side effects that you can get. So, when I treat Glenn, I get an OCT every time they come to see me because we want to make sure they're not getting CNV or neovascular AMD. And then, the demotivation happens and fatigue happens, and you have to continue to counsel. If you get a side effect and the treatment burden becomes too high, then sometimes we have to stop treatment. So I think, when we have patients, right, we have to look at their imaging to start. And our 72-year-old patient with early foveal sparing GA that we started the program with, we see the hyperautofluorescence, they'll grow, the diagnosis is early, there is foveal sparing, and then we look at the FAF, and then we look at the OCT to compare. So let's go to some more polling question here. So pull up your cell phones. And so this patient has foveal sparing early GA that we discussed, and has meaningful remaining vision. So what is the best approach for this patient where we have early GA, foveal sparing, and good vision? So go ahead and answer. I don't know if this will be 100%, Glenn, because it's a variable doctor-physician-patient discussion. Okay, 100%. That's good.
Very good.
Great. People are paying attention. I like it. So again, the bottom line in conclusion is that 3 things to carry in clinic tomorrow: recognize the disease early, treat the disease if the patient is the right candidate and they understand the risk-benefit profile, treat early if you can, so you can preserve more retinal tissue and function for them, and then monitor closely to make sure that they're not getting side effects. In the last 3 minutes, Glenn, let's cover the post-test and see how the learning has been. This morning, we were bright and early with a lot of coffee in the room. So going back to the pre-test question we had now, this is post-test. On spectral domain OCT, which single finding best defines GA under the CAM consensus, distinguishing it from the drusen and pigmentary changes of intermediate AMD? So please go ahead and answer, and let's see what the learning was. This is related to your talk, Glenn, so if there's no learning, you may not be invited again. People are thinking, see, they like you. They want you to come back, so.
Oh.
All righty.
I just mentioned subretinal hyperreflective material and intraretinal subretinal fluid is neovascular AMD.
All right, the 2 FDA-approved intravitreal therapies for GA both act on the complement cascade. Which statement correctly pairs agent with its molecular target? So if you like me, please answer properly.
Very good. They like you.
All righty. Number 3, 70-year-old man, left eye, foveal sparing GA 2040, enlarging towards the fovea, fellow eye, central GA, count fingers vision, wants to preserve his reading left eye. What's the best next step? Please go ahead and answer. So one eye is bad, the other eye is progressing, but still not involving the fovea. What's the best next step for this patient? Obviously discussing the risk and benefits.
And assume that it was not Stargardt's disease.
Yes, it's real GA. Great, 100%. This is a good audience. We should have you register for every program we do because this is the best I've seen, especially this early in the morning. All righty. Question 4, 73-year-old women, right eye on intravitreal complement inhibitor for extrafoveal GA returns for a monitoring visit. What's the most appropriate imaging strategy to track progression and screen for treatment-related complications? This is Glenn's question.
Very good. End on a high note.
Everything is 100% here. This is like amazing. All righty. I think we are running out of time. Is there any burning questions from the audience? Yes.
When you have a patient that after the first injection develops neuropathy, how do you manage that case?
Yeah, I think so. Glenn, I'll answer quickly. So obviously, if you have inflammation, you have to treat it. And then the question becomes is, are you going to re-challenge that patient with that drug or are you going to switch to another drug? So let's say they're on pegcetacoplan and they get inflammation. You treat that and then the discussion comes in whether we continue the therapy with pegcetacoplan or we actually switch. Because inflammation could be immune response, could be, impurity. So my preference usually is if I get inflammation, even for wet AMD with one agent, I usually don't repeat the same agent. Glenn?
Same way.
Because we don't know if it's immune related or not, or it's impurity. And then the optic neuropathy, I've not have it in my practice, but there is not much management, I think, to do other than obviously maybe referral to neuro-ophthalmologist.
No, same thing.
Great. I think we made it on time. Thank you again for being here bright and early. Scan the code to get your credits and enjoy the rest of the meeting. Thank you so much.